Hello, welcome. My name is Kathy Antala, and I am the Vice President of Education for the Immune Deficiency Foundation. Thank you for joining us today. Before we start today's session, I would like to go over a few reminders. First, please remember that each patient's treatment and condition is unique. The content presented in this session should not be used as a substitute for professional medical advice. In all cases, patients and caregivers should consult their healthcare providers. Also, please remember that where you are on your journey of living with primary immunodeficiency may differ from that of others. The severity of PI can vary, and we ask that you are supportive and respectful of one another as fellow members of the IDF community. Today, questions for our presenter will be answered at the end of the presenter's talk. Please submit your questions in the question box located at the bottom of your screen, and then our presenter will answer as many questions as possible during this time. It is my pleasure to welcome you to our breakout session, IG therapy, IVIG, and subcutaneous IG tips and tricks. The session will be presented by Dr. Beth Younger. Mary Elizabeth Younger is a doctor and assistant professor of pediatrics at Johns Hopkins University in Baltimore, and she has received her undergraduate degree from the University of Virginia. Dr. Younger is a recipient of the Immune Deficiency Foundation's Art of Nursing Award, which is presented to a nurse who has made substantial contributions to the care of patients with primary immunodeficiencies. It is my honor to welcome Dr. Younger.
Thank you, Kathy, and thank you to you all who've made me part of your pre-football game tailgate. I do not have a ton of slides because I want to make sure that there's lots and lots of time for questions so that you get the information that's important for you. So on we go. I do have some disclosures. As you can see, I do consulting work for virtually all of the manufacturers of gamma globulin, just to let you know. So let me start with what is immunoglobulin. I'm betting you all know the answer to this. It's a plasma product. It's not necessarily a drug per se. It's a product that comes from blood, and it's manufactured from the plasma collected from thousands and thousands of donors, and that number really varies depending on who you read and when. The numbers are as low as 10,000 and as high as 60,000 of people. So that's a huge number of donors. And I'm sure John sometime during this conference has talked about the importance of plasma donoring, which is a little bit of a problem during the current pandemic. But basically it's a solution of antibodies. And it has the antibodies that all of the donors carry. So if a particular donor has had a particular disease, they have antibodies against that disease. If they've been vaccinated against that disease, then there's antibodies that were made in response to that vaccination. So gamma globulin has antibodies to measles and chickenpox and pneumonias caused by strep pneumoniae, has antibodies against Epstein-Barr virus that causes mononucleosis and other infections. Unfortunately, when you have viral infections, like during the current pandemic, it may not have antibodies toward that particular disease. And right now, there's no COVID-19 in the current supply of gamma globulin. And the reason for that is because the plasma that's in your gamma globulin that you're giving yourself today or this week or whenever was collected 18 months to 2 years ago. There was no COVID 18 months to 2 years ago. Nobody had disease, so nobody made antibodies. And there's still no vaccine, so nobody's made antibodies in response to the vaccine. So if there's a new illness like COVID, There's no antibody in the gamma globulin for that in particular infection. And that's important to know. That's a question that my patients ask me all the time. When am I going to get COVID-19 protection? And my answer, unfortunately, is in about 18 months or 2 years, when people who've had that virus are giving their plasma today. So that's an important thing to remember. And it's similar with the flu vaccine. People have antibodies to lots of influenza viruses. If that's the influenza virus that's around this year, that's great. But if the influenza that was around 2 years ago that people made antibodies to is not the influenza that's around this year, you may or may not have protection against this year's strain of influenza. And that's an important thing to remember. You know, patients will get flu and they'll say to me, how did I get the flu? I've been doing my gamma globulin every week without fail. You know me, I never, ever miss. Unfortunately, there was no antibody to this particular flu strain in the current supply. So that's an important thing to remember. The next thing you need to know is that gamma globulin is almost 99% IgG. There's very, very little IgA or IgM in it. So people look at their numbers. We monitor numbers 2 or 3 times a year. And people say to me, well, how come my IgA and my IgM are still really, really low? They're really low because I haven't replaced it. There's very little A or M in gamma globulin. And really, that's not so important. It's IgG that's really going to give you the protection that you need. The last thing to know about gamma globulin is one of the things I say to new people on therapy all the time is that it's absolutely as safe as it possibly can be. I know that nothing's ever 100%, but gamma globulin is as close to 100% as it can be. It's manufactured with multiple safety steps. The donors are selected and screened, and then the product itself has viruses inactivated and removed. So it's as safe as it possibly can be. There's not been anything that anybody knows has been transmitted through gamma globulin since 1994. That's a pretty long time ago at this point in time. So so what it's not, and it's not a cure. Unfortunately, it's never going to make your system make its own antibodies. It's just going to give you what you can't make for yourself. And I think it's a little bit like gasoline. You know, if the engine's broken, gamma globulin's not going to fix the engine. It's just going to give you gas so that your car can go. And if you don't get it, you're absolutely going to run out of gas. So it may be a little bit of a silly analogy, but it's important to remember. It's also important to know that it's not a cure for an acute infection. And a lot of providers don't realize that. They'll say, well, somebody's in my office sick. Do you think I should give them an extra dose of gamma globulin? Nope, it's not going to cure an acute infection. So, okay. So there's a couple of things when you're on IG therapy that you absolutely have to remember. And the first thing that I stand on the top of my soapbox and lecture all my people about is you absolutely need to know the name of your product and what dose you're on. It's really important. And it needs to be on your list of medications, even though, as I said, it's not a medication per se. It's something that you're on, and all of the people who take care of you need to know about it because it can affect your care. It can affect some of the things that people want to do to see what's wrong with you. Your prescriber, again, will look at your blood levels to look at IgG levels and look to see if it's having any adverse effects on your system, but your A and your M are not going to be changed. The next thing to remember is that routine vaccinations are probably not necessary. Most people are on gamma globulin because they didn't respond to a vaccine. So we give you the antibodies that you couldn't make for yourself. Now, some providers do give vaccines. I have a colleague in Minnesota. She says, yeah, sure, we give everybody their vaccines. We don't here at Johns Hopkins, here in my kitchen at Johns Hopkins. You need to talk to your prescriber, but I have a lot of patients who go to their internist and their internist says, well, it's time for your Prevnar or your Pneumovax. And it's completely unnecessary. People are on gamma globulin because they didn't respond to Prevnar or Pneumovax. So getting another shot is pointless. Same thing I tell my patients, when they step on a rusty can and go to the emergency room to get the cut sewn up, and the emergency room whips out a tetanus shot. My people don't need tetanus shots. There's oodles and oodles of tetanus antibody in gamma globulin. And the last point that goes back to why it needs to be on your med list is that it may have an impact on other therapies that you need or diagnostics that are done. I frequently get phone calls from somebody that says, well, I have hepatitis B. And my question is, well, how do you know you have hepatitis B? It's because some provider ran an antibody test to see if they had hepatitis B antibodies, and their antibody numbers were very, very high. Well, they're very, very high because there's oodles of hep B antibody in gamma globulin. So when doctors do antibody tests, they're going to give false reports. So it's important that your providers know you're on gamma globulin so they don't run those tests that are going to give false information. So who needs replacement therapy? The people that definitely need replacement therapy are people with common variable immunodeficiency. They're people with agammaglobulinemia, people who don't have any antibody at all, and those people born with severe combined immunodeficiency. Those are the three absolute definites. People who maybe need it are people with selective antibody deficiencies, people with dysgammaglobulinemia or hypergammaglobulinemia. Those are people who make oodles and oodles of IgG, but it doesn't do anything. All it does is clog up the system and doesn't give you specific antibodies to help you fight infection. And then there's a bunch of syndromes, Wiskott-Aldrich, DeGeorge syndrome. Those patients may have a significant antibody problem. They may need immunoglobulin therapy. They may not. Your immunologist is definitely going to evaluate you and decide if immunoglobulin is right for you. So the goal for therapy, as I said, it's never going to cure or fix your immune system. The idea is to provide protection against severe or frequent infections. When I start people on gamma globulin, I sit and I say, I would love to tell you, you're never going to get another cold. Sorry, you are going to get another cold, but hopefully we're going to prevent the cold from maybe leading to a post-viral bacterial infection that ends you up in the hospital. And that's the goal for therapy. So this is Kathy Antola's favorite part. Immunoglobulin is a little bit like ice cream. And I know that it sounds a little funny, but ice cream's ice cream, but you can have it multiple ways. There's multiple brands. People like it, some brands better than others. Some people like a little ice cream. Some people like a lot of ice cream. And you can always do death by chocolate. And as I said, I don't mean to be funny, but that's what gamma globulin is like. There's multiple brands. There's multiple doses. Some people like one brand over another. There's people that eat ice cream, they're clueless about what brand they're eating. There's other people that swear that there's nothing like Ben & Jerry's, and other people will swear there's nothing like Haagen-Dazs. And that's really what gamma globulin is like. As I said, I don't mean to be silly, but Kathy Antola tells me she likes the ice cream slide. She says it makes sense to her. So there's lots and lots of options for therapy, just like there's lots of ice cream. So there's products to be chosen. There's routes of administration and timing. Gamma globulin, as some of you know, can be given intravenously every 3 to 4 weeks. It can be given subcutaneously every day up to every 14 days. And then there's the facilitated subcutaneous product that's given generally every 2 to 4 weeks. The site of care is an option. It can be home. It can be in a hospital-based infusion suite. It can be a freestanding infusion suite. And there's lots of things that can be manipulated in there. I used to have a gentleman who did it in his car as he was driving to work on Monday mornings. He'd pop in his needles, he'd throw the pump on the passenger seat, and by the time he commuted into Washington, D.C., he was done with his therapy for the week. So your car is a possibility. So, as I said, there's decisions. There's all these questions that need to be answered. What route do I use? Can I do it myself? Do I want to do it myself? I have a lady who says, you know what? If you ask me to stick myself and lock me in a closet, she says, I'm going to die in the closet before I ever stick myself. She clearly doesn't want to do it herself. That's fine. She doesn't have to. All of these questions need to be answered and considered. And you need to figure out what's right for you. So a quickie slide. These are the immunoglobulin products that are available in the United States right now. By law, the FDA says that all gamma globulin given in the United States has to be made from plasma that's collected in the United States. So it's going to be a collection of antibodies from other Americans. It's not going to be antibodies collected from people in Europe or Africa or South America. Now, the products, generally, the plasma is collected and the plasma may be shipped to Europe. There are a lot of manufacturers in Europe, but it's still American plasma being made into gamma globulin in Europe and then coming back. Right? So there's multiple intravenous products. The reason the subcutaneous products are listed where they are is that each of those products is a more concentrated version of the IV product. So GammaGuard Liquid is the IV product. The SubQ product made by the GammaGuard folks is Cuvitru. Same story with Gamunex C, can be given IV or SubQ, but the concentrated SubQ product is Zembify, which is relatively new to the market that people are starting to try out. Again, Octagam is the IV product. The Octapharma product for SubQ use is Cutaquig, and that's the newest on the market. Privigen, IV Privigen is SubQ Hizentra, made by the Behring folks. And HyQvia is the only facilitated SubQ product, so it's the last one. So you're absolutely going to be getting one of these products if you're on gamma globulin replacement therapy. So this is the important slide, and I hate it when people apologize for busy slides, but I apologize for the busy slide. So in the left-hand column are the different parameters that you need to think about. Frequency of dosing, as I said, IV can be every 3 to 4 weeks. Facilitated SubQ can be 2 to 4 weeks. SubQ therapy can be given every single day, up to every 14 days, depending on how you want to do it. The important box is the next box for those of us who are prescribing. Our goal is to make sure our patients have consistent levels of IgG that protect them. So most of us strive to keep that level as constant as we possibly can. When you get IV drug, that level goes up very quickly because you're putting a lot of IgG into the circulatory system and it's being switched around your system very quickly. And then it generally goes down over about 21 days, which is the half-life for gamma globulin. SubQ gamma globulin, there's very little variation in the IgG level because you're constantly replenishing it. It's a little bit like if you think about your system as a bucket with a hole in it and you want to keep the bucket full of fluid, you can either let it almost totally empty and then fill it all at once with a ton of fluid, or you can top off the tank, as it were, a little bit at a time. And the first way is IV. The second way of topping off the tank is SubQ. Okay. Access may be an issue for people. IVIG obviously needs IV access, and that does not include a port. The immunologists in this country and around the world are pretty united in saying that ports are not a good idea for people with immunodeficiencies. Obviously, SubQ gamma globulin doesn't require IV access, but it does require somebody who's willing to stick themselves. Needle sticks, usually one for an IV if you've got good veins. SubQ, the number of needles, it's a different kind of needle, but it can vary depending on your dose and how often you want to do it. An IV infusion generally takes 3 to 4 hours, plus or minus, depending on your dose. SubQ gamma globulin can be given very quickly. Each of the products has parameters that that people follow that say it needs to be delivered over this amount of time, but there's significant literature that talks about people just pushing their gamma globulin without using a pump and pushing it as quickly as it's tolerated. You'd be interested to know that in Canada, the national insurance does not provide pumps for gamma globulin, so everybody in Canada pushes their gamma globulin just with their thumb and a syringe. And they do those pushes very, very quickly. I actually was telling Kathy Angela earlier that I started a 10-day-old, a brand new patient with severe combined immunodeficiency. I started him on gamma globulin in my clinic on Friday, and I pushed his little teeny dose in about 2 minutes. And he was totally fine. You need some help for IVIG. You need a nurse or a healthcare professional. People for SCIG can do it independently after they've been trained. With regard to side effects, there are definitely side effects associated with IVIG. Usually that's because, as I said, you're giving a huge dose of IgG and you're putting it quickly into the circulatory system. With SubQ, you're putting it someplace where there's no hole for it to go into. You're putting it into tissue where it's being picked up by microscopic vessels and it's going into your system extraordinarily slowly. So people generally do not have systemic side effects with SubQ gamma globulin. Those people who have problems with IVIG sometimes need to be pre-medicated so they can tolerate their infusions. Subcutaneous gamma globulin does not require any pre-medication. The reality is that if I gave myself a SubQ infusion right here as I'm sitting talking to you, and I measured my IgG, and I measured it again tonight, it would be almost the same number. The SubQ gamma globulin doesn't get into your system in any huge amount for 24 to 36 hours. So my IgG level wouldn't even change till tomorrow if I gave it to myself today. So pre-medication is pointless. There's always a but, no systemic side effects, but sometimes people get some local side effects with SubQ gamma globulin. They get a little swelling, they get a little redness. Sometimes people have a little bit of itching, sometimes some burning. All of those things go away, and we definitely have things that we can manipulate if those kinds of things are problematic. Most frequently, it has to do with the length of the needle that you're using. And if we change the length of the needle, we eliminate that burning and itching. Portability, you need a big pump for IVIG and for facilitated SubQIG. So it's really not portable. SubQ is totally portable. I have plenty of patients who are business travelers who throw their gamma globulin into their travel luggage. I've sent some college kids on semesters abroad laughingly with a backpack full of gamma globulin, and they do their infusions while they're in wherever they've gone for their semester abroad. Cost is the last thing you need to think about. Not necessarily, this is not an end-all and be-all list, but these are the high points. So there is absolutely a cost for drug and infusion when you're doing IVIG. When you're doing facilitated SubQ or regular SubQ, you're only paying for the drug and supplies. You're not paying for any ancillary help. So in a nutshell, that's the things that you need to think about and the things you need to consider. The differences in the options, whether they're important, whether they're advantages or disadvantages, should absolutely be determined by the prescriber and you. As a prescriber, I feel strongly sometimes that one particular method is better for a patient than another. But I still have to consult with the patient and tell him what I think and why I think. Ultimately, the decision is his. And when I talk about the differences, I really never call them pros or cons. I say these are the differences. You need to decide for yourself whether it's a pro or a con. But that decision has to be made together. If you hate your infusion regimen and every week it's like, oh my gosh, I have to do it again. Or every month it's, oh my gosh, I have to go get another infusion. You need to speak up for yourself. You absolutely, positively have to have a discussion with your prescriber and say, this is what I really hate. Can we fix what I hate? Can we change something up? Can I try something different? Actually, almost all, not all, but almost all of the manufacturers of gamma globulin have a trial program if you want to try SubQ. I know a lot of people who've been on IVIG for a long, long time say, well, I don't want to rock the boat. I've been doing it this way for X number of years. It seems to work okay. So I'm not going to change. I'm not going to rock the boat. But if you are in that particular position and you want to try a SubQ product, almost all of the manufacturers have a trial program where they'll supply free drug, free infusion supplies for X amount of time so you can just try a different way of doing things. You may decide you like it. You may decide you hate it. You may decide, yeah, IV was definitely better for me. But you're making that decision. Nobody's making that decision for you. So a little bit, my last slide is remember that there's ice cream for everybody. And as I said, I didn't do 6 tons of slides because I wanted to make sure I had time for your questions. So that's the information that I really wanted to get to you. I love this ice cream. I just wanted you to know that.
Oh my goodness, Dr. Younger, thank you so much. And thank you for talking about the different flavors of ice cream.
I knew you'd like that, Kathy.
Oh, you are wonderful. Well, here we go. We have lots of questions for you, and they are really good ones. So we'll have you, I'll drill you with questions now, and we'll have you answer as many as possible in the time we have remaining. Our first question is, I am new to plasma administration. The only place I have enough fat to place my subcutaneous needles is my belly. If I administer plasma every week in the same site, will I develop scar tissue or any visible changes to my abdomen?
Okay, so that's question number 4. It's also question number 6. And that's a question that I get a lot. So those of us who teach and do a ton of SubQ gamma globulin, and you need a disclaimer here, I'm currently prescribing gamma globulin for 500 people, and over 90% of them are doing SubQ infusions by themselves. So I have 500 people doing this therapy. Those of us around the country who do prescribe a lot of it will tell you that changing sites is not something that you need to do. I tell people not to look for the same hole, but the same general area is a really good thing because it does 2 things. First of all, it gets the cells in that area a little bit mushy, so they move aside readily and don't swell up and don't push back as much. And the cells in that area get used to the gamma globulin, so they don't try to reject it as something foreign. So I have people that have put it into their tummy for years. They do an infusion. They come into my clinic the next day for their annual appointment. And I say, you did your infusion last night. Where did you put it? And they're like, well, right there where I always put it. There's no swelling. There's no redness. So no, you don't generally develop scar tissue. There's a question down also about they only use their tummy because they don't have a lot of fat. I will tell you that the one area that every single person in the world has is a little pad of fat on their hips. And I love the hip spot. And I love it because it's not underneath your waistband or your pants. It's out of the way. And the way I find and locate that spot for people is I have them sit in a straight back chair. I have them put the heel of their hands on their hip bone and point their fingers to the floor. And if you all do that as you're sitting right now, under your fingers, you'll feel a squishy pad of fat. Every single person has that pad of fat, and it's a great site for gamma globulin. I actually have a 20-something-year-old patient who's a baseball catcher. So he has 6-pack abs. I mean, he's pure muscle from head to toe. And he's got thighs that are like rocks because he squats up and down as in his catcher position every day. Even he has that pad of fat on his hips, and he uses his hips. So, and I actually started an older lady on Friday in my clinic who weighs about 80 pounds. And needless to say, she has very little fat, but she has 2 little pads of fat on her hips, and that's where I put her gamma globulin. So that's my personal recommendation for a terrific site if you feel like your tummy's not working for you. And that's the site I go to for my pregnant ladies too, when they can't use their tummies anymore. So no, you do not have to rotate sites. No, you will not develop scar tissue.
Thank you. Next question. How do doctors choose which product a patient is given? Upon my diagnosis, my immunologist prescribed a brand that I reacted to. I wasn't aware there were other brands until I had the reaction.
Yeah, so I will tell you that most of us have a product on formulary, if those of us who work in a hospital. And I generally start with the product that's on formulary because I know if my patient needs to be admitted to the hospital, that's the brand that I'm going to get most readily. If somebody has a reaction, I absolutely change products. Sometimes it's an insurance question. Sometimes insurances will pay for one product and not another. I don't change people's products once I get them established on a product and I demonstrate that they're tolerating it extraordinarily well. I don't change it. But that slide I showed you about 10 slides ago, those are the products that are available right now. And if you have a reaction to a particular product, then absolutely you can change products. Generally, as I said, it's a little bit like ice cream. All the products are virtually the same. They're all equally efficacious. They vary a little bit in how they're made and how the viruses are taken out, but they're virtually the same. They're only different when it comes to patient tolerability. So I think most of us go with our tried and true when we start prescribing, but I have no problem changing a product if somebody demonstrates intolerance.
I see that the plasma is mostly IgG, but since there may be a little IgA, can infusions help increase the IgA? If
No.
not, how can I increase IgA?
There's absolutely no way in anywhere in the world. There is no way to increase IgA. There is no product that you can give yourself. There's no supplement that you can take. There is nothing that will increase your IgA.
How about increasing IgM? We have a question
Same story.
Okay.
There's absolutely no way to increase your IgA or IgM. There's no product that replaces those things and no supplement you can take that will replace those things. Basically, with the IgG that's important, if you'll let me do Immunology 101 for half a second, IgM is a huge non-specific molecule. If I can go back to the rusty can that you stepped on a bunch of slides ago, the first reaction your body makes when you stepped on that rusty can is IgM. And your body cranks out a lot of IgM because it's been infected. And that IgM, because it's very smart, recognizes that that's tetanus. And the IgM then does what's called class switching, very official word. But what it does, it switches from IgM to tetanus-specific IgG. So when we give you gamma globulin, we're bypassing that non-specific IgM step and giving you the disease-specific IgG.
We have a couple questions about facilitated SubQ versus regular SubQ. People are wondering what is facilitated SubQ versus regular SubQ, and also can facilitated SubQ apply to anybody regardless of their antibody deficiency?
Okay, so yes, facilitated SubQ is a different way of administering immunoglobulin. Basically, with facilitated SubQ, it's a two-part process. You give yourself an enzyme called hyaluronidase. Don't ask me to spell it. It's Sunday. I don't think on Sunday. Hyaluronidase. And what that hyaluronidase does is it sort of breaks down the skin matrix and makes it possible to put a larger volume of fluid in the subcutaneous space. So people who do facilitated SubQ give themselves hyaluronidase, and then it makes it possible to put a large volume into that SubQ space. So people put 2 to 3 weeks of gamma globulin in that spot. So it's a way to do less frequent infusions and give yourselves a little bit more gamma globulin at one time. It does require a big infusion pump. It has a little bit more steps than just regular SubQ gamma globulin. in terms of providing consistency of IgG levels, it's kind of between IV and SubQ. So you don't have a huge IgG peak and then a decline or a straight level as with regular SubQ. You have something in the middle. You do get a little bit of a peak, you get a little bit of a decline, but it isn't as significant as it is with regular IV. So it's just a different way of doing your therapy. And it's something to consider if you hate doing weekly infusions, or you hate doing every 3 to 4 week IV infusions and you want to try SubQ, but what's turning you off about SubQ is frequency. So it's just one more thing to consider.
Do you have any tips for scarring? It looks like bruising on my toddler's legs. The upper thighs are the only place he will tolerate the infusions right now. His legs look so banged up.
Oh, poor pumpkin. So it's really a little bit of some sclerosis, and it will absolutely go away if he's got what my girlfriend at Duke used to call was pearls. And she used to say, there's people that get little pearls at the site. Those will eventually go away. I would suggest absolutely good. I can go back to using a hip site for your toddler. And I put toddlers in front of their computers and come up behind them and pop the needle into their hip, and they don't even realize it's in their hip. I love that spot. But scar tissue or sclerotic areas will absolutely go away. But there's not much that you can do for them. They're just going to resolve over time. Obviously, you want to avoid them. You don't want to you don't want to try to stick any of those spots.
I'm going to change to subcutaneous infusions next month.
Okay.
I'm currently receiving IVIG with a 10% product. And now I will be switching to a different product, 20%. I'm worried because it is a different brand and I might have a reaction. Are there any 10% solutions I can use to infuse subcutaneously?
Okay, so there's a bunch of answers to that question. Both GammaGuard and Gamunex are approved for IV or SubQ. The beauty of SubQ is that it's all about the volume. So why would you put 20 cc's into some place where there's no hole for it to go into, where you're going to have to push cells aside, when you can do 10 cc's and give yourself exactly the same dose? The 20% product is what made SubQ gamma globulin just so workable for everybody. It's all about the volume. You want to give yourself the smallest volume possible. I don't know what product you're on, but there are SubQ products now there's an Octagam SubQ product, there's a Gamunex SubQ product, there's a GammaGuard SubQ product, there's a Privigen SubQ product. I would bet that you're on one of those IV preparations and you can absolutely go to the SubQ version of that IV drug. But I would not recommend starting SubQ with a 10% product. As I said, it's all about the volume. You want to give yourself the smallest volume possible, and larger volume is going to increase the length of your infusion. I don't know if timing is important to you. When I start patients, I say, how long are you willing to devote to this? And they say, as little time as possible. And that's exactly what kind of regimen I prescribe. I prescribe fast infusions so that people's lives can move on. It's a little blip on the radar screen. It doesn't necessarily need to be the thing that the whole week revolves around. So as I said, if you're on an IV product that you like and you're switching to SubQ, ask your doctor if you can switch to the SubQ version of the current IV product you're on. But I would absolutely not recommend starting with a 10% product. You'll like it much better if you use a 20% product. As I said, it's all about the volume.
With the 21-day decrease of IG levels with IVIG, would you recommend going from monthly to every 3-week infusions intravenously?
That's a question you need to talk to your immunologist about. I will tell you that I don't have anybody doing IV every 4 weeks. We do our IV infusions every 3 weeks for that reason. Other people feel a little bit differently. And if you're very well protected and you're never sick, then probably every 4 weeks does work for you. The reason that some of us changed were because we noticed that people were getting sick in that week before their infusion. And when we changed them to every 3 weeks, they didn't get sick. It's what we call a trough sensibility. That low level is called a trough. And there's some people who have a wear-off effect after 3 weeks or so, or their trough gets a little lower than they can tolerate, and they find themselves getting sick or feeling run down that week before their infusion. That's a question you absolutely should ask your provider. You should discuss that with him and say, so do you think that maybe that's a problem, and that maybe every 3 week infusions might be a better way for me to go? Or maybe switching to SubQ would be an even better way to go. Again, it's knowing what the options are and advocating for yourself to get what's the best therapy for you. You know, I prescribe for all these people, and I say to them, I don't live your life. I don't know what it looks like for you. I need you to tell me how you see this therapy and how you see it being part of your life. The day it becomes your life is the day we have a problem. As I said, it needs to be a blip on the radar screen that you do every week, every other week, every 3 weeks, whatever works for you. But it has to work for you in your life. And if it doesn't, that's when we have to have a conversation. And I say this to my patients all the time. And my patients change the way they do things. I was telling you about my guy who used to do it in the car when he drove to work on Monday mornings. Well, he retired. And I said, so what are we doing about those Monday morning infusions? And he said, I want to go to every 2 weeks. He said, I don't want to do it every week anymore. I want as much time as possible to be doing all the fun things that I've been missing while I've been working for 40 years. And he did. He went from weekly Monday morning infusions to every 2 week infusion, and he's happy as a clam.
Thank you. Unfortunately, our Q&A time has come to an end, and we have many questions still left. So what we will do is we will follow up with Dr. Younger and those of you who have asked these questions, and we will make sure that you get some answers. It might take a few days, but we will follow up with you. So at this time, I would like to thank Dr. Younger for her wonderful, wonderful presentation. Thank you so much. And thank you to everybody who submitted all these wonderful questions. And please hang around, because in 15 minutes, you will get a lot of your questions answered about plasma. There is a keynote session coming up at 12 p.m. Eastern Time. It is called The Power of Plasma, Person to Person, the Process Beginning to End. And it is presented by somebody from PPTA. And you'll find out what PPTA is if you join the session. And then the summit comes to an end at 12:45 today, when we will hear from our president and CEO, John Boyle. So again, thank you, Dr. Younger. Thank you for everyone for being here. And we will see you in a bit.
Thank you, everybody.